So the next speaker is Dr. Amber Deptola. Dr. Deptola is a medical educator at Washington University. Can you tell us a little bit about your current practice model and your position?
Sure. So I'm at an academic center, so I'm an associate program director for the residency program. So a lot of my patient care takes place in the academic setting, or actually all of my patient care takes place in the academic setting. It also all takes place in the supervision of residents and students. So my current practice is down at the medical center, seeing primarily underserved patients in collaboration with the resident physicians, and we oftentimes have students that join us for those clinic sessions as well. So typically, our patients are scheduled with the resident, and then the residents will come and after they see the patient, will come and staff the patients with us and discuss the patient's concerns, their concerns, and we come up with a plan that is then conveyed to the patient. Whether or not I see the patient kind of depends on what the patient is presenting with. So some patients are coming in for relatively routine visits, maybe feeling well, and some of those patients may not need to be seen by an attending, but other patients who may be seen for hospital follow-up visits or are acutely ill or have a physical exam finding that may warrant some additional review will be seen by both the resident physician and myself.
So I know that I think some people in your division have their own panel of patients in addition to the patients they see with residents. Do you have a separate panel of your own patients?
So I do not. There is a diverse range of sort of clinical obligations amongst the academic faculty within our division at WashU. So some of our faculty spend more of their time seeing their own patient panels. Some spend more of their time seeing patients within the co. Not all of our faculty have their own panels, and so it really is person dependent. And in addition, many of our faculty that see patients in the outpatient setting also see patients in the inpatient setting on the academic service.
How did you end up doing this? What made you decide this is the kind of thing you wanted to do?
So, I mean, I think I primarily ended up here due to my interest in medical education. So my interest in medical education within medical school consisted of, watching a lot of general internists and hospitalists teach in the classroom and then in the clinical space. And so those were the people that I really felt like I identified with. And I felt like there was a lot of opportunity for teaching and learning within internal medicine, just given the depth and breadth of disease and health prevention that we see in internal medicine. And truthfully, my career has been varied in terms of practice setting. So I started out doing 5 years in hospital medicine. I think a lot of that initial decision was based on my practice comfort. So my residency training was a lot of inpatient care, like a lot of residency training is right now. And so I think residents naturally feel more comfortable in the inpatient setting than the outpatient setting because of that. And with that in mind, I really at the time felt like I would be unprepared to step into an outpatient practice directly from training. So I wanted some time to kind of better understand what my clinical skills were, and decided at that time that doing hospital medicine was the best initial route. And then over those 5 years in hospital medicine, I found that I really wanted to be able to connect with patients on a deeper level and prevent those hospital stays that I was seeing all the time as a hospitalist. And so wanted to transition my time towards more outpatient medicine that was geared towards those sorts of things.
So does that happen in your practice? Are you able to prevent hospital admissions? Do you have continuity of care with the patients you see?
So we do. I think the amount of continuity is definitely variable amongst, when you're talking about resident clinics, the continuity is variable just given residents rotating schedules. At our clinic, there has been a huge movement to improve the continuity within the clinic. And so we've moved to a team-based model that at least enables some level of continuity for our patients. So even if they're not seeing the same resident physician, maybe I would be the physician that's staffing that patient. So if I, saw the patient in their post-hospital visit, and then I'm seeing them 2 months later to see if the medication regimen is still the one we want and need, there is at least that level of continuity. It's very different though from, community and private practice, or even in the academic setting where a single physician has a single panel, where there is, where the structure is with the purpose of continuity. So there's definitely a little bit of a difference there in the resident clinic, but it's certainly more continuity than I had in the hospital setting.
Are you exclusively ambulatory in your practice, or do you have hospital rotations as well?
So I am completely ambulatory now. I may at some point go back to doing some inpatient medicine. So for me, when I made the transition from that inpatient to outpatient, again, coming back to this idea of, what skills do I have and what skills do I need in terms of the patient care I'm trying to provide. My goal was to really focus on that outpatient care so that I could, skill build in this area. Part of that is tied to my responsibilities in education. So I also oversee the outpatient medicine curriculum for our residents. And so having that knowledge and skill set was really important to me when I made that transition from inpatient to outpatient. So I am currently entirely outpatient. I might at some point add back in inpatient, but I didn't want to dilute that learning opportunity when I made that transition.
So the residency program you trained in, I'm not current on the statistics at this time, but historically, the number of residents who entered subspecialty training was in the high 80s. I'm guessing that it's still in that ballpark. Did you did you consider subspecialty training, and or do you have any second thoughts about not having done that as opposed to doing what you're doing?
So I definitely, no second thoughts. I do not think subspecialty training would have been the right thing for me. So when I entered residency, I had this idea that I was going to be a hematologist, potentially a benign hematologist. And, reflecting back, I think that goal was really swayed by this one, great clinician that I rotated with during medical school, who was a hematologist and who I saw as a role model. And so, if I had to then, if you set out all the specialties in front of me and I had to pick one, well, that was the one, because that was where there existed a role model for for that specialty. But I found over the course of residency, well, one, my primary goal in a career was to be a medical educator. And so taking that into mind, yes, you can be a medical educator and do a specialty fellowship, though I would say if you look at the range of medical educators, many of them in medicine, or most of them in medicine, are probably general internists. I think we're seeing more and more of a shift in that. So it'll be interesting to see where that goes. But I think part of that is that, in subspecialty training, kind of more things get added to the pile in a way. So oftentimes what I see, right, is like the research engagement grows, and it's hard. It is really hard to be that triad that we used to speak of. So to be a strong clinician and to, hold grants and do research and run a research team, and to be a medical educator. So when I kind of looked forward and thought about how my time would be spent, and I wanted it to be spent doing education, from that alone, subspecialty training maybe didn't make sense for me. And then the other thing that occurred is I realized this goal of going into hematology was probably swayed by this one individual, and that I didn't necessarily feel attached to that specialty for any other reason. And to me, choosing a specialty sort of felt like I was giving other things up in a way, if you will. And I didn't want to do that. I wanted to keep the broad clinical approach that sort of that first line for presentations and diagnosis and next steps.
I'm interested in the way people use language. People often speak of benign hematologists, but they rarely speak of malignant oncologists. Do you have any thoughts about why that is?
Probably just for the way it sounded when you said it.
So how do you spend your time? What's a typical day like?
So given that I do a lot of medical education work, that is how I'm spending a lot of my time. So at current, I'm probably about a third clinical, a third direct teaching time, and a third like administrative time. So my clinical time, I'm in the resident clinic supervising patient care and getting notes done, doing epic tasks, all of those sorts of things. And then the other third that's direct teaching is these days teaching a lot on Zoom on this platform, but usually in a classroom type setting, and sometimes still in a classroom type setting. And then the other third is administrative. So it's making sure that the functions of the residency program, which I oversee, are getting done, that the team that I manage within the medical school and building a curriculum is resourced and able to do what it needs to do. So what that amounts to is a lot of Zoom meetings and a lot of emails.
What was the best part of it?
The best part for me is probably the direct teaching. I personally find that to be a very rewarding part of my job, and even more rewarding when I see that translate into the clinical space. So I've been lucky in that, I know what the residents are learning when they're learning it in ambulatory didactics. And so, let's say we talked about prostate cancer screening in the morning in didactics, and then I go into clinic in the afternoon and we staff a patient who came in requesting a PSA for prostate cancer screening. So being able to talk with the resident about how they've applied that information that they learned in the morning to this patient that they're seeing in clinic is extremely rewarding, because it allows me to see, what stuck with them from what we discussed, and then how are they going to use that to then, discuss, in this instance, prostate cancer screening with their patient. So it enables me to see that translation, which is, the goal, right, of medical education, is that we see that translation to our patients.
Well, what's the least pleasant or most distasteful part of your job? What if you see it on your calendar for a given day, fills you with dread?
I mean, I was going to say meetings, but I feel like that's a little too broad of a statement. To me, it's really interesting over the past year how we've attempted to sort out, I don't know, or maybe we're failing at identifying what needs a meeting and what needs an email, et cetera. So the convenience of the Zoom meeting has been something that's troubled me over the past year. But I'd say, a good number of meetings are, well, one, really important for community building, especially in this time when we're not seeing a lot of our colleagues in many ways. And then certainly meetings can be very productive, and you can feel like you got things accomplished at the end of them. But that's probably not every meeting. So there is this uncertainty when you see the meeting on the calendar as to how far you'll get, and what the mutual understanding is of the goal of said meeting.
So tell me about work-life balance. Have you come, you're now, 6 or 7 years out of medical school?
Yeah.
How many years out of residency?
No, 6 or 7 out of residency.
Out of residency, okay. And have you come close to feeling burnt out, or feeling overwhelmed, or feeling like your life was out of balance because of your work and your family and so on?
Yes, and I will add on to that. Who hasn't? I imagine I would be very, very doubtful if somebody told you that they've experienced no burnout or moments of distress. I think that's probably a natural part of life in general, and certainly seems to be quite common amongst physicians. So the group that you're interviewing. I mean, I think some of it is, especially in academic medicine, there are like busier periods and less busy periods. And so I certainly have periods where I feel generally like more relaxed and like I'm accomplishing and efficient and on top of my work as I need to be. And then periods where I feel like I'm constantly behind and trying to play catch up and meeting the demands of my job. I feel like over the past 6 to 7 years, I've gotten slightly better at being reflective in thinking about, how I'm feeling about what I'm doing and how burnt out I am at any moment, and thinking about why that is and what I can do about it. And so simple things like, so for example, this conversation we just had about a meeting, trying to, at first my scheduling would be like put all those meetings together, but that would be the worst day ever. Like the end of that day for me would, I would probably feel like I got very, very little done and would probably feel pretty solidly burnout at the end of that day. Like I needed to step away from my computer and step away from my work for a while. Tank is empty. And so even just, recognizing those things that drain us and being purposeful about trying not to schedule those together are small things. And then kind of from a larger perspective, reflecting back on what are the things that I'm doing right now that I really enjoy doing? What are the things that I enjoy doing less? It doesn't mean you can get rid of everything that you enjoy doing less. So for example, meetings are going to be a part of my career. So I will never get rid of meetings. That would be an unrealistic attempt at change, but being reflective at least enables us to better be able to, say yes and say no as opportunities arise when we can. And that is generally the advice that I give residents as they're, thinking about their career forward, especially if they are feeling, burnt out by the clinical demands of residency, those sorts of things, and thinking about, what about the job that you have right now gives you energy and what drains you, and how can we sort of maximize on those things that give you energy.
What are your call and weekend responsibilities?
So I don't have any right now. I get an occasional phone call from a resident after hours when labs come back and, the potassium was 2 or the potassium was 7. It seems to always be the potassium that results in after hours phone calls. So I'll get phone calls for like patient, follow-ups from clinic essentially that need to be addressed on a somewhat acute basis. But I do not have weekend call. So this doesn't mean that I don't work on the nights and weekends. I just say the work is a little bit different from people that might spend more of their time doing clinical work. So it's not infrequent that that full-time clinicians, especially in the outpatient setting, may spend time in the evenings doing notes or time on the weekends doing notes or taking call from their clinical practice. For me, 10 p.m. might be, tinkering with a presentation the next day or writing cases for a case quiz for the residents, those sorts of things. And so, I think we all try to kind of, distribute our time based on the demands of the job and life at the moment. And in the academic setting, I think that ends up that nighttime and that weekend call end up being translated into, preparing to teach, some of those administrative duties, writing papers, trying to publish, those sorts of things.
You think that your current job structure gives you adequate time and control of your life vis-a-vis family responsibilities?
Yeah, I think so. I think, as a physician, there's always going to need to be some level of integration, right? I think it's hard or near impossible to sort of close off that a piece of our life and make it work still. I'm really lucky in that I do, as I mentioned, how I spend my time, a third of that time is administrative time. And so that time gives me some flexibility to be able to schedule those meetings around other needs. Or, my son's on spring break currently, so he's at a rocket science camp, but he gets done at 3 p.m. today, which would be earlier than the usual. So to schedule meetings and those obligations based on those momentary needs of life and family.
Do you feel like you're fairly compensated for your workload?
I think so. I probably the biggest variation that you might, I don't know, see in these interviews is difference between like academic salaries and other salaries. Though I think all salaries sort of titrate based on the amount of patient care that you do, right? So how are others compensated results in the compensation that you end up receiving as a physician. And so certainly the variation between academic and private practice will, I assume, be a big one in these interviews. But for me, it's what I really love to do. And so I think feeling like you're adequately compensated, if I hated my job at my current pay rate, which is much below the average of physicians in general, that would be a different story. But I think if you love your job, it doesn't mean that you can't negotiate and ensure that you're getting paid fairly based on standards of your community. I think that's still important, but there's a willingness, if you will, to love the work that you do and be compensated based on that standard.
So I suspect that many members of the audience watching this will have had no experience with negotiation. Do you have tips for them on how to negotiate to obtain fair compensation?
So I suppose I've negotiated for 2 jobs. And so first off, I'd recommend us also asking others this question as well, who may have done more or been on the other side. I think an important piece is understanding what your work is worth, right? So if somebody's recruiting you, first of all, recognize that you're being recruited, and that you are worth adequate compensation, and then figure out what that adequate compensation is. So try to understand what people are being paid for similar work, and explore that data a little bit. Also looking at what if you've held a prior position. So this is assuming you're not coming just from residency, what you were paid before, and what does this look like in terms of career advancement for you. The other thing that I'll throw out there is, so there is salary, but there's also other ways of being compensated, such as loan repayment. And so, especially in the academic world, there's often ceilings in tiers of payment, upon which institutions are unwilling to go further. But there are other ways that they could compensate you if it is, felt to be inadequate. So also being creative and thinking about how you could be compensated for your work if that tiered payment does not either work for you for your family, if you don't think it's inadequate in terms of an advancement perspective, or if you just need more.
So what resources did you use to find out, what fair compensation was for your job?
So it's been a couple of years now, and I'm not going to remember unfortunately, the exact resources that I used, but there are, I think Doximity puts out some numbers, so that can be a good resource, and I'm not remembering the title of that page, but they put out some resources in terms of salaries. I also have personally found social media to be somewhat valuable in terms of shared resources of adequate compensation, and that's not like a publicly available thing for folks to look at. And then I also used some trusted resources internally. So just, essentially, here is what is on the table. Can you talk to me about it?
So I'm naive about social media in this regard. What social media venues? Reddit, Twitter, Facebook?
So for me, there's groups on Facebook that I found to be a valuable resource. So specifically physician women, there's multiple Facebook groups in which there is information sharing. And there's a lot of information sharing about appropriate compensation, just, given the statistics on compensation for women. It's been a really valuable resource for me. So that obviously doesn't speak to the full audience here, but for me, finding some trusted groups on Facebook was valuable.
Thanks. So again, the audience, the primary audience here is going to be residents who will be graduating soon. Presumably, the prospect of leaving training focuses your mind on the next step. What advice would you have for somebody looking for their first job post-training?
So it really kind of depends on what that what their interests are, I'd say. I think from a general perspective, it is probably a good idea to apply for, be interviewed in, sort of get to know at least a few variations of whatever that practice interest is for you. So for example, if you want to be a hospitalist, in Chicago, at least interview with a few hospitals, get to know the people, get to understand the structure, get to understand what the compensation looks like. Interviewing in multiple places will help you to understand what to expect and what is kind of fair and unfair. I think that's really hard to judge when you're leaving training, when sort of everything's been sort of like presented before you and you take it or you take it or you don't have a job. It's very different to have options, right? And things that you can walk away from. So that will help you to understand what that standard is, certainly. That also enables you to negotiate a little bit better. So if you have, a few offers from different hospitals, you then have numbers in front of you that you can use to negotiate, which can be a nice strategy as well. And then the other general advice that I'll give is, have at least a few people look over your contract when it comes through. Many physicians have a lawyer contracts. I think the language in contracts is really confusing. And so even just being able to interpret what is meant by various things such as non-competes can be really difficult out of training. So sometimes out of training, you don't have the finances to pay a lawyer $500 for that initial review. And if that's the case, okay, but at least get, a trusted mentor, maybe a friend, maybe somebody also who's non-medical or somebody that you know in law, even if you're not hiring them, to look over that contract and find points that maybe, opportunities for negotiation or points that may be in need of clarification of intent or meaning. And the nice thing about, jobs out of residency, right, is it's very different from residency where you kind of, you chose something and you're stuck, if you will, for 3+ years for whatever you've decided. And so once you enter that job, it's also, asking yourself frequently enough, how is this going? Do I, is the work that I'm doing abiding by the contract that I signed? What do I like? What do I not like? If I had an opportunity to change, what would that look like? Because at some point, somebody's going to ask you. And so having that understanding can be helpful for that natural evolution that I think takes place in most physicians' careers.
Any red flags that they should look out for? Anything that should cause them to run screaming in the other direction?
Unhappy people. Really, I mean, right. So if you go to when you go to interview somewhere, for the most part, the places where you're interviewing are putting on their like, best face, best foot forward, right? Wine and dine this person. It's a little weird in pandemic times, but some similar circumstance usually exists. And so If the people that you're meeting with seem really unhappy or seem really unexcited about the work that they're doing, it's one thing if it's a single individual and might be personality. It's a very different thing if it's multiple people that you're meeting with, or if people don't like show up to meet with you, or don't want to be engaged in that recruitment process. So to me, those are major red flags. The other kind of red flag that I sometimes advise my residents on, though this doesn't seem to be the case very many places these days, is if there are a ton of open positions for which it seems they've been recruiting for quite some time. That should give you pause on why that is. So, and it may be the salary, it may be that the job is advertised to be, a daytime hospitalist job, but actually in the fine print, it's, oh, you'll work all the nights that we need you if we need you. And that ends up being the job. So just kind of being aware of, what does this feel like? Are the people happy? And then, if the opportunity has been available for a long time or seems a little too good to be true, make sure you question that and probably ask more questions of the place you're interviewing.
We're coming to the end. Is there anything that I didn't ask that I should have, that you think you should, information or experience that you should share with residents looking for their first positions?
I think the only thing that I'll add in is, I think this is an area where it's really helpful to have mentors and trusted advisors for you to talk this through with. And so, in residencies, sometimes those are like naturally existing people who have been assigned to you in some way to help you with this process. Use those people. Tell them what you're thinking about and why, and your opportunities and where you're at on that. And they really might offer you useful insight. And then, if you have trusted mentors, I think those are also really valuable when making these sorts of decisions. Your mentors want to see you succeed, and so they'll be able to think a little more longitudinally about what this initial opportunity looks like based on goals that you've communicated to them. So they can be really helpful for not like the nitty-gritty logistics maybe of the job, but helping you to see how some of your decisions may impact those goals that you've defined for later on.
Right. Thanks very much for taking the time to talk to us today.